Hospital. And on 20th July, that is next Thursday, we have slide seminar on clinical significance of IHC and molecular diagnostics in CNS tumors by Dr. Ipari Sridhar. So with this, let's begin our interesting talk for today. Over to you, Geeta ma'am.
Good evening to all of you. And first of all, let me thank Dr. Sumit Gujral and Dr. Anita for setting this up and inviting me to do this session. We were just talking earlier about how amazing it is that such something like this is done for postgraduates, and I'm honored to be part of it today. Before I begin this session on pediatric brain tumors, particularly gliomas, one of the things that is very important to us in interpretation is radiology. So I've requested Dr. Kadri to first just show a few slides to give you an idea of what we look for on radiology before we interpret our biopsies. Dr. Kadri?
Thank you so much, ma'am. So I'll just make a very short presentation to give a very basic idea to our pathology residents here that what we are looking for in an MRI. So I'll just go full screen. Yeah. So let me start. So whenever we are talking about pediatric brain tumors or any brain tumors per se, radiology is extremely important because radiology is a key to your diagnosis and your interpretation of pathology also. So basically in radiology, we look for two things, the anatomy, because especially for pediatric brain tumors, it is extremely important because your diagnosis changes a lot. In fact, you can predict some of the molecular or diagnosis also depending upon the origin of the site of or the location of the lesion. So what we look for is basically the location and the sublocation. So whether it's an infratentorial or a supratentorial tumor, it's a midline or off midline, whether it is arising from the parenchyma or whether it's ventricular or extraction. And finally, we look at if it's a supratentorial, then which lobe it is arising from, and then whether it's a gray matter lesion or a white matter lesion. So all these information is made available to you when you look at the radiological images. And finally, the margins and the signal characteristics in MRI, and these are also equally important because they give you an idea about a preliminary provisional diagnosis or differential diagnosis of what kind of tumor you are actually looking at. So let us come to the first thing, that is the location. So what we do is, this is the MRI, so we acquire MRI in three planes. This is the axial plane. I just put a pointer. So this is an axial plane, this is the coronal, and this is the sagittal. We have to look at a lesion in all three planes because it gives us an idea about the three-dimensional anatomy of a lesion. And so, for example, we have to look whether it is in the supratentorial compartment, whether it's in the ventricle, whether it's midline, off midline, if this part is the supratentorial in the coronal section, the brainstem, or in the cerebellum. So we have to look at a lesion in all three planes to see what is the orientation of the lesion in relation to the anatomical structures of the brain. Another important thing which we should see in the sagittal section is the pituitary, and we will see some of the cases where we can see lesions in these regions and how to interpret the lesions in these regions. So another important thing for you before you interpret any MRI is you have to remember it is opposite of what we see. So this is the right side in MRI and this is the left side, right? Next is the margins of a lesion. So margins of a lesion can be circumscribed and diffuse. And how do we interpret that? Look at this one, this image. We can see there is a lesion which is present in the basal ganglia. It's a very well-defined lesion. How do we say it is well-defined? Because the margin of the lesion could be very well delineated from the adjacent normal parenchyma. Whereas on the lesion on the right, where we see that the outline of the lesion is not very well clearly delineated from the adjacent normal parenchyma. So this is a diffuse lesion, and this is a very circumscribed lesion. And therefore, for example, if you're talking about gliomas only, there are circumscribed and diffuse gliomas. So this gives you an idea whether it's a circumscribed lesion or a diffuse lesion. Coming to the next slide. So the basic sequences that we have to acquire in an MRI are which are important for you to interpret when you are noting down differentials of a lesion include these two. First is the T1 and the T2. Now remember, T1 is a basic anatomical sequence. How do we say that it is a T1 weighted sequence? So in T1, the gray matter which is on the outside is gray and the white matter is white. It is very easy to remember. Gray is gray and white is white in T1 weighted image, and the CSF appears black. The exact opposite of this is the T2 weighted image, in which the gray is white and the white is black. So basically the white matter appears a bit darker and the gray matter appears a bit brighter and the CSF appears bright. So these two are exact opposite of each other. We should remember the T2 weighted image is an extremely important image, and this is the first image which we have to look for whenever we are trying to interpret the anatomy and as well as interpret any lesion. So for example, we are looking at this is a normal MRI of infratentorial part of the brain where it is seen. So this is basically the fourth ventricle, the pons and the cerebellum. So these are two lesions. Both are midline lesions. Both are located within the fourth ventricle. However, if you observe carefully, this one appears a little bit bright. So whatever appears bright is called as hyperintense. Whatever appears dark is called as hypointense. And what is hyper and hyper as compared to? So we compare it with the signal intensity of the gray matter. So if we have to compare the signal intensity of the lesion with the gray matter, so if it is brighter than the gray matter, we say it is hyperintense. If it is darker than the gray matter, we say it is hypointense. So basically, this gives us an idea about the cellularity, or in if we can extend it to the grade of the tumor in some cases. So basically, the cellularity is very well depicted by this. So here we can say that this is generally a hypocellular tumor or a lower grade tumor, whereas this one is a higher grade tumor. Coming to the next section, so I'll be teaching about only three sequences which will be very important to you. First is the T2, second is a diffusion with an ADC. So what is DWI? DWI is a diffusion weighted imaging, and ADC is the corresponding image to that, which is called as the apparent diffusion coefficient. These two are always read together. And how do we identify the sequence? It's a very dirty looking sequence, so where you can't see the skull and everything appears not very clear to you. For as pathologists, you can remember this much only. So that is the diffusion weighted imaging, and these two images have to be seen together always. So in DWI, the CSF appears black, in ADC the CSF appears white, and the rest of the parenchyma appears black in ADC, and the rest of the parenchyma appears bright in DWI. This is how you identify. Now, what do you mean by diffusion restriction? Diffusion restriction means the normal free flow of water is restricted, basically in tumors, generally due to the high cellularity of that tumors. So diffusion indirectly gives you an idea about the grade of the tumors. There are other reasons of diffusion restriction also, but you to grossly remember, the higher the diffusion restriction, generally the higher is the grade of the tumor. So for example, we looked at the first tumor. We can see here that it is not bright in diffusion and it is not dark. So what we told was bright in DWI and dark in ADC means a higher grade, or that is called as diffusion restriction. This is non-restrictive. Whereas the second one, it is showing bright signal on diffusion weighted imaging and dark signal on ADC. So therefore, this is diffusion restriction, and therefore this is likely again a higher cellularity tumor. The last slide, the third, that is another very important thing that you should know is the post-contrast. So the post-contrast sequence is generally done on a T1. How do we identify this as a T1? Because the gray is gray and the white is white. And how do we know this is post-contrast? Because we can see this white thing inside the vessels. So this is basically gadolinium-based contrast agent. And why do we give this? We give this to enhance the contrast or to see the tumor better. And it not only shows us the tumor better, it tells us that there is a loss of blood-brain barrier. So normal parenchyma of the brain does not enhance because the blood-brain barrier is intact. Whereas a normal tumor, it enhances because the blood-brain barrier is broken down. So depending upon the type of enhancement, also we get a lot of idea about what kind of tumor we're looking at. So the first tumor which we saw, it is showing intense homogeneous enhancement, whereas second tumor is showing heterogeneous, ill-defined enhancement or a patchy enhancement. So I will not correlate directly with the higher grade or lower grade depending upon the types of enhancement, but yes, it will give you an idea depending upon all. So we look at the T2, we look at the diffusion, and then we look at the contrast. It will give you an idea about what kind of tumor you're looking at. So apart from this, also there are other advanced sequences like SWI, like perfusion and spectroscopy, which I'm not going into details of because it doesn't make sense in this particular class, but that also helps us to narrow down our differentials. But these basic sequences, if you remember, then it will help you in first of all locating the tumor and getting a basic idea of what kind of tumor you are looking at. So with that, I end my presentation and I hand over to Geeta madam to start kindly.
Thank you very much, Kajri. That was a really nice overview to start off with. I know you're going to do another presentation at the end. So without any further, let me try and share my screen. Is my screen visible and full?
Yes, ma'am.
Is it full screen?
Yes, ma'am.
All right. So today I'm going to be talking about pediatric brain tumors, particularly glial tumors. And before I go into that, I just want to get a sense from the participants about what you think, how frequent is brain tumor in a child by age group. So in the 0 to 14-year age group, Anamika, how frequent do you think brain tumors are in children? Are they rare? Are they frequent? Just say something, doesn't matter.
Ma'am, they are frequent.
They're frequent. What about Burjesh? 15 to 39 age group, do you think it's very common?
No, rare.
Huh?
I think
So-
it's rare.
Yeah,
Rare.
you need to speak a little louder.
Okay.
So you feel that the 15 to 39 it's rare, and in the 40 plus? Shatabdi?
It is intermediate. It may be
Intermediate. So you'll be surprised to see that in the pediatric 0 to 14-year group, it ranks as the most common brain tumor. It's followed only by leukemias. And in the 15 to 39, it ranks second. So I'm just showing you this for you to understand the importance of these tumors in young adults and children. That is the second most common tumor in the 15 to 39. And it's lower down in terms of its frequency in adults. So extremely important when to know this, that young children can, 0 to 14 years, it is the most frequent tumor that occurs. Now, when we see a brain tumor, of course, the histology matters to us as pathologists. And more recently, immunohistochemistry and molecular alterations have also gotten important in making a diagnosis, not only for diagnosis, but prognosis and treatment. But also important are, like Kajri said, the site of the tumor. That affects what we consider as a diagnosis, the age of the patient, because different age groups have different tumors that are more likely to happen. The radiological picture, like Kajri showed you, that has a lot of information for us. And extremely important also are the operative findings. One thing I haven't mentioned is the duration of symptoms. So when one gets a biopsy, the factors that one has to think of even before putting the slide on the microscope is what is the age of the patient, what is the duration of symptoms, what is the site, how does the imaging look, and very important to communicate with the surgeons to know what they have seen. Okay, whether it's a vascular tumor, whether it was, sometimes they give you very little tissue, but you have to understand then that that's because it's in an eloquent area and they cannot biopsy more. Or if it's from the brainstem, they do a stereotactic biopsy. That is a guided biopsy, which is extremely small. But when you see it along with all this information, it helps you to make a diagnosis. And as we go along, you'll see why. So going by site, in the brain and spinal cord, overall, glial neoplasms are very frequent. When one encounters a tumor in the brainstem, again, it's glial neoplasms. In the temporal lobe, it's mainly low-grade tumors like the pleomorphic xanthoastrocytoma that Dr. Vani showed you, and the descendroplastic neuroepithelial tumor, which also she showed you in the last session, and the ganglioglioma. When one sees a tumor in the ventricle, there is no hard and fast rule that only these tumors occur, but these are the more frequent. You get what are the ependymomas and the neurocytomas. If the tumor is in the cerebellum, if it's high grade, one considers a medulloblastoma. Pilocytic astrocytomas and hemangioblastomas are cystic tumors with neural nodules.